I think on behalf of the Devager Center Climate Change and Indian National Chapter of ComHAD, United Kingdom, and Lakeside Education Trust, we are organizing this monthly program. This month is the celebrate the National Parkinson Disease Month. And the topic selected is Parkinsonism, risk recognition and measures to mitigate. Wherever you are, good morning, good afternoon, good evening from the UK people and Australia people, the ComHAD people are 54 countries. And to inaugurate this subject, the topic officially, we want none other than, in the absence of our chief chairman, S.K. Satish, we want Professor J. Srinivasan. J. Srinivasan is a graduate from IIT Chennai, and he got a gold medal. He's a gold medalist. Yeah. And he did his MS in state of New York and PhD in the Stanford University. And he's the founder of this institute in 2009. Can you hear? Can you hear? Yes. We are in the good environment and it won't bite. And we have emergency drug, adrenaline here, EpiPen, because the yellow jacket has got highest sting anaphylaxis. So now I think he's the founder of the Devager Climate Change and is the past chairman of this institute up till 2016. And he's currently the emeritus distinguished professor at the Devager Climate Change till date, and honorary professor, Center for Atmosphere and Oceanic Studies in the Institute of Science till date. And he's a lead author for the second and fourth IPCC report on climate change and a reviewer editor for the third report. His major scientific contributions are in the areas of monsoon models and climate change. And he published over 125 research papers on climate and thermal science. And he received Lifetime Achievement Award by the Ministry of Earth Science 2019. Various awards are there. As far I know of, he don't want to mention about it. His uncle is none other than late Nobel laureate Sir C.V. Raman. And I know him for the past 4 years. Very simple man. He lives inEshwaram, comes in the bus, from the institute, comes in a bicycle here, goes away. And such a simple, honest, right for upright man. And also academic, he has got so much knowledge, certain point he can highlight. Is an inspiration, any academic field, he enjoys it. He never missed any one of these programs for the past 18 months. We have been doing it as a link between the society and scientists and the doctors. Keeping that in mind, I request Professor J. Srinivasan officially welcome the guests and inaugurate the conference before I take it over. Over to you, sir.
Thank you, Doctor. Let me just, on behalf of Professor Satish, welcome you all to this monthly seminar series, which has been organized for the past 18 months. And we have been having eminent speakers every month to talk about various facets of health and the environment. And today's topic is very relevant to many of us to do with Parkinsonism. And I request Dr. Pramit to introduce the speaker for today's seminar.
So thank you very much, sir. Now, today's topic we discussed about it. Just to make some introductory remark about the subject before introducing the subject, basically introducing the speaker and chairman. So what I look into the literature myself as a medical doctor, not as a specialist in motility syndromes. The Parkinson disease is a neurodegenerative condition which progresses relentlessly over number of years without any cure. In addition, Parkinson's can occur secondary to other conditions, example, encephalitis, anaphylactic drugs, side effects, and vascular disease and head injury, etc. Age is the largest risk factor. About 1% of the people over the age of 60 years and 5% of the people over the age of 85 years are high risk group, and men suffer more than the ladies. The exposure of the pesticides, environment related issue, so a small thing we have. Exposure to the pesticide, rotenone and paraquat, which also has been linked to the Parkinsonism in its users. Trichloroethylene, a solvent used in many industries and organic containment in the groundwater. Heavy metals like iron, manganese, lead, copper, exposure to carbon monoxide also contribute for the Parkinsonism.
Introduction.
It is essentially a clinical diagnosis consisting of unilateral onset of tremors, rigidity, bradykinesia, postural instability, and the tremors, and rigidity, bradykinesia, postural instability, and excellent response to the Levodopa therapy initial stages. There are several markers, clinical, biological, and imaging and genetic to identify the disease before it is clinically manifest and plan for preventive measures as and when necessary. Very intriguing and interesting potential protective factors have been reported recently. I'm a little confused here myself, being air pollutionist, avoiding tobacco smoke. That's one of them is that my request for that, don't recommend tobacco smoke, anything like that, sir. Maybe the nicotine can be utilized. Maybe you can utilize that one. So this is what my personal request. I think has been done that higher dose vitamin D, drinking coffee often. We just had a coffee. And drugs like ibuprofen, statin for the cholesterol reducing, these exercise is good enough. These are some of the preventive measures what we can follow. No doubt, we need further research to identify the disease in the beginning stage and take measures to mitigate. To talk about this important subject, we have none other than Professor H.V. Srinivas. He did his Doctor of Medicine and Doctorate of the Neurology, and he's working currently at the Sagar Hospital and Apollo Hospital in Bangalore. Earlier, he was a postgraduate teacher in the DNB in Neurology, Narayana Institute of Neurosciences, and he got many oration awards. The first one, S.C. Bazoria Oration, and K.S. Mani Memorial Oration in Kochi, and IMA Dharwad Diamond Jubilee Oration in 2010, Tirupati Oration in Epidemiology, and Govindappa Memorial Oration in Mysore Medical College. Govindappa was my assistant professor in medicine. And KSS Appa Oration from Karnataka, and the Lifetime Achievement Award received from Newcon in 2012, and Lifetime Achievement Award from Madras Neuro Trust 2017. B.M. Sharma Oration, Indian Epilepsy Association. He has held many important positions in Southeast Asia Regional Executive Committee. He was the chairman, and he is the president of Indian Epilepsy Association Central Office, president of Indian Academy of Neurology, president of Karnataka Neurosciences Academy. He got many books for his credit, Guidelines in the Management of the Common Neurological Disorder in 2011, and he edited the book called A Saga of Indian Neurology, and he also edited the Saga of IEA, 40 Years of Journey. Authored a book on Manual Epilepsy, Medical Management and Social Aspect 2015. Co-editor in Handbook of Epilepsy for the Physician 2019. I know we worked together for 25 years, a man of simplicity. If he Srinivasan says, everybody has to agree. That has created impression in the neurology. He was in NIMHANS and all. Once Srinivas says, that is the final authority. I think this is what it is in Karnataka all over. Epilepsy, nobody can touch you. Having done that one, this important talk is chaired by another eminent personality, a youngster, the sportsman, the none other than Prashant. Dr. Prashant is here. He has also done his neurology in NIMHANS, DM, and fellowship in movement disorders in Toronto, Canada. He is a specialist Parkinson disease and other movement disorders at Manipal Hospitals, Bangalore, and also is a founder member of the Movement Disorder Society of India, treasurer Movement Disorders Society of India, and executive committee member of the Asian and Oceanic section of IPMDS, member of the Global Parkinson Genetic Program, editorial board of Movement Disorder of the Clinical Practice Journal, and also moving along with the newsletter in IPMDS, and editorial board of International Parkinson's and Movement Disorder Society website. He is also many publications to his credit, over 60 of them, as a matter of fact, as a peer-reviewed journals. And his interest is PD genetics, DBS, apomorphine, botulism, toxin therapies, and therapeutics. With all these things, I think once there was a conference, people are sitting in the bar. One is having little shaky hand, other with mild Alzheimer's together. They're sitting in the bar. And they ask, if you want some degenerative disease, as we go older, we have to face it. Which one would you like to have it? I said, I would rather have a Parkinsonism. Why? I don't forget where I kept my drink. This is what we say about it. And sir, over to you. Take it over. We'd like to hear you introduce the speaker. Go ahead. Sorry. Professor Prashant.
I don't think I should take much time here. And Professor Srinivas has been introduced well, and we all know. Professor. So I think Professor Srinivas has been introduced well enough, I think, for this August audience. Let him take over the dais and present his topic, and then we can discuss about Parkinson's and how we can work around that and how to mitigate Parkinson's in the coming years. Thank you.
I like to acknowledge the presence of our chairman of the Comrade Country, Yashwant Patil, and also Dr. Chaparwal, who are the president of the Indian Medical Council, and the Ahalya Devi, Rani Ahalya Devi University Vice Chancellor, and two other Vice Chancellors are there. And Kalyan Sundaram is also there. And indeed, we are a pleasure to have all of them on the virtual side. Thank you, sir.
At the outset, I should thank Dr. Parmesh, my old friend, for having me on this occasion to give a talk on Parkinsonism. And I also thank the organizers who have done this job and our chairperson, Dr. Prashant. So the occasion for this talk is the World Parkinson's Day. As you are aware that many of the medical conditions we have International Epilepsy Day, Hypertension Day, Diabetes Day, and all that. The whole idea is to have some amount of public education about these common neurological disorders. Today we are talking about Parkinson's Day. Even though the day is supposed to be 11th April, we usually celebrate during that week or at least during that month to create awareness among the public about it. Now, the title of my topic, as has been given Dr. Parmesh, is So the title is Risk Recognition and Measures to Mitigate. Now, as you can see in the photograph there, the Parkinson patients, the stooped posture is a very common presenting feature you can make out from a distance, but Don't ever think that whoever is having a stoop posture has got Parkinson, because stoop posture is common as we grow old, especially if we are not doing exercises properly. So now to begin with, what is Parkinsonism and what is Parkinson's disease? They are totally two different conditions. Parkinsonism is a syndrome, that means a group of signs and symptoms consisting of rigidity, that means the muscles are very stiff, and that is the basis why the patient's movements are all slow because of the stiff muscles. And also there is a bradykinesia, that means slow movement. Even though the patient may not have stiffness, yet the patient may have slow movements. Of course, it is compounded by the stiffness also. The second important point is the tremors. Every tremor we see in elderly patient is not Parkinson's disease, because time and again we get references, sir, do I have Parkinson? Most of them have not Parkinson, but it is called as essential tremors. And finally, a combination of rigidity and bradykinesia results in a gait disorder. That means they are very slow in walking because the muscles are stiff. Now, Parkinsonism. What are all the conditions which come under Parkinsonism? The one which we are going to discuss further is the idiopathic Parkinson's disease. This was described by Parkinson, a British physician, more than 200 years ago. And that is the original idiopathic Parkinson's disease. Over a period of time, there were many other conditions with stiffness or tremors or bradykinesia, but not the original Parkinson's disease. It was similar to, but not the same. So the similar conditions, which was mimicking Parkinson's disease, is grouped under the Parkinsonism. Now, what are those conditions? We'll see the first is secondary Parkinsonism. Now, the very word secondary means that it is secondary to some other existing disease. So some other existing disease with features of Parkinsonism, that is called as a secondary Parkinsonism. The commonest what we see in clinical practice is the long-term use of antipsychotic drugs. Patients who are on psychosis problem, either schizophrenia or bipolar disorder, they are on a long-term, larger doses to control their symptoms. And invariably, some of them will end up with Parkinsonism, where we may have to reduce the drugs or use alternately. The other thing which I see in clinical practice is anti-vertigo. There are many patients who continue to take anti-vertigo drug Sinarrazine. Sometime back, 10 years back, it has been prescribed. And you know, in our country, people are all self-medicated. And without prescription, you can get drugs. So they'll just go and say, give me Sinarrazine or some other drug like Stametil, etc. They do get it. So every time they have giddiness, they keep on swallowing it over a period of 10 years. And they come with Parkinsonism features. Then there are other conditions like head injury, brain fever, hypoxia, and all that. So all of these, to re-emphasize, they have features of the underlying disease. On the top of it is Parkinson's-like features. Then we have the vascular Parkinsonism. So as the name suggests, the Parkinsonism is due to lack of blood supply to some structures in the brain. Now, this vascular Parkinsonism is due to small areas of lack of blood supply in the brain. And when does it occur? Like any other cause of stroke, hypertension, diabetes, cholesterol problem, smoking. So all the risk factors for hypertension also gives rise to this sort of a thing. But the only thing which is confused for Parkinsonism is the gait. They have short shuffling gait, but they do not have tremors. The upper limbs are not affected. So it is quite easy to differentiate vascular Parkinsonism from the original Parkinson's disease. And vascular Parkinsonism and secondary Parkinsonism are eminently preventable because it is due to some other condition. So if you treat that condition like hypertension, diabetes, you may mitigate these symptoms or even reverse it also. And lastly, under the Parkinsonism, we have what is called as a Parkinson plus. That means in addition to Parkinson's disease, the patient has some other neurological problem, not what we are talking about, drugs or hypoxia like that. They have another neurological problem like dementia the patient may be having, or they may be having some, they may be having autonomic disturbances with postural hypotension. So these are all the subset of the atypical Parkinsonism or Parkinson plus. Now we come to the real topic, that is the idiopathic Parkinson's disease. As the very word idiopathic says, we don't know what is the cause. In fact, many times when the patient asks, sir, what is the cause? Epilepsy, we treat epilepsy patients. Sir, what is the cause? Sir, what is the cause for dementia? What is the cause for Parkinson? I said 90% of our medicine is we don't know the cause. So we put a word idiopathic. Tremors are we don't know, we say essential. We don't know what causes blood pressure, so we say essential hypertension. But we know how to treat the patient. The reason we may not be able to know, but we are still searching. We don't know why BP occurs. We don't know why diabetes occurs. We say it is due to insulin deficiency. Why does insulin deficiency occur? We don't know. So most of it is we don't know. So also the today's topic of Parkinson's disease. Now, how do we recognize idiopathic Parkinson's disease? First topic. You may be surprised and to know that James Parkinson, a British physician, in 1817, more than 200 years ago, described this condition in an essay, which is titled it as shaking palsy. Shaking because the patients have tremors, palsy because they are walking very slowly. It is not total paralysis, but it is because they are walking very slow, the movements are slow, so it is considered as a palsy. And what is more important is he reported only 6 cases, 3 of which he observed on the streets of London. We observe many things on the street of Malleshwaram, but we don't look at the patients or any center. Something else is more interesting. But that man has described it so well. Even today, that clinical description is what is most important for diagnosis, even today. And the Parkinson's, he has made a name that we keep remembering him for the rest of everybody's life. Even after 200 years, we are remembering him. Only 6 cases which he has described so elegantly. We all were trained before the CT scan, MR scan. Most of it was all medical descriptions of the diseases were a clinical observation and clinical follow-up. Those days we had time for clinical follow-up, we had time for clinical observation, we had time for talking to patients. But today, the patients and doctors alike, all investigation based. The moment a patient enters my room, we'll put a MR scan. Sir, MR scan notice, sir, L4-5 disc prolapse. MR scan notice, sir, there is a block of the vessel. I just, what is your problem? I have got a blocked vessel in the neck, sir. I said, that is the diagnosis given. Why did you go to the doctor? I have to really ask so many questions to take the history. So today, the clinical observation, everything has gone. Clinical medicine is dying, if not already dead. I must say that. So how do we diagnose idiopathic Parkinson's disease? It is entirely a clinical diagnosis. In spite of all the high-tech investigations available today, the diagnosis is purely by looking at the patient and having the history. What James Parkinson said, tremors, bradykinesia, rigidity, gait, all of them were same. The only thing he has also added unilateral onset. The only thing we have added is excellent response to Levodopa. It was not there at that time, of course. So that is a very important hallmark for the diagnosis of Parkinson's disease. Simply because Parkinson is due to deficiency of Levodopa. So if you replace it with Dopa replacement, the patient must improve dramatically. If he's not improving, that means your diagnosis is wrong or the drug is not branded one or something like that. Now we have about 6 to 7 million patients in India, and it is the second most common neurodegenerative disease, second only to dementia, Alzheimer's dementia. Now, what is the Parkinson's disease due to? It is due to a dopamine deficiency. mouse is there so that I can point out something. Okay, so it is due to substantia nigra. The dopamine is being, granules are there, which is secreted, and then nigrostriatal pathway, there will be a deficiency of dopamine. So if the dopamine secretion becomes less due to degeneration of the concerned neurons, the patient will start having these symptoms. And what is the pathology there? It is because called as a Lewy bodies, which is nothing but aggregation of a type of protein, synuclein. Please remember this synuclein protein, because as I go along, how to recognize Parkinson before it manifests. This synuclein is the one benchmark to say that probably this patient is going to develop. The second most important is 60 to 70% loss of dopamine should be there before the patient develops the symptoms. Nature or God, whatever you may say, is so generous. They have all given us the extra. For example, renal failure occurs only after 1.5 kidneys fail, not even one kidney. The remaining kidney also, half of it should fail before the patient develops the renal failure. So one kidney is actually bonus. That is why people give the donation kidney. 2 eyes are there, 2 ears are there, 2 lungs are there. See, everything we have got a spare part. Even though the spare part is there, sometimes when the problem happens, only after the spare part is also utilized. So 2 important points in this slide. Number 1 is 70% loss of dopamine is required for clinical disease. Number 2 is the bottom line is the presence of synuclein protein. So which we are using these 2 points to identify before the Parkinson's disease manifests. You big small screen over. Oh. Is in the name. I'm just trying to show some clinical picture of the tremors and all. Okay, let's keep it. So this is a tremor, which is called as a resting tremor. You see, when the hand is rested on a table, at that time the patient has got tremor. This is very classical of a Parkinson's disease. When the same hand is put out as a posture, the tremors disappear. So some people come with a tremors of the hand when they are putting it out or when they are drinking a cup of coffee. But that is not Parkinson's disease. Parkinson is classically, as happens when the patient is keeping the hand rested on her own thigh or on the table. Next. Sorry, you don't mind 2-3 minutes extra. Next. This is also another patient with a resting tremor. He has just kept it on his thigh, and you can see the tremors disappear when there is an action. Only on resting it will be there. See, on action, the tremors disappear completely. Go back. Next slide. Next slide. We talked about bradykinesia. So see his left hand is moving very fast. The right hand is very, very slow. That is called as a bradykinesia. So the movement, even though there is a full motor power, his ability to do fast movements are completely gone. So that is called as a bradykinesia. on the right side. Parkinson's disease always starts on one side of the body. So right hand and right leg. Yes. Now you see the gait, the way that she is walking. See, what happens is these people develop what is called as a freeze gait. As they are walking, they suddenly freeze. They say that, sir, as though there is a magnet in the earth, it's not allowing me to lift my foot. Now you see that how she is walking, shuffling gait, and then she's stuck. Right hand is having a resting tremor, and she's not able to take her feet off the ground. That is called as a freezing gait. It is as though there is a magnet in the earth, not allowing the feet to go. So this is a very, very disturbing feature for Parkinson patient, because when they are going into the market or going to somebody's house, as they are walking, they are completely stuck. They are trying to get the feet off. So these are all the problems: bradykinesia, tremors, resting one, and the gait, having a freezing gait. So these are all the clinical symptoms. As I said, the diagnosis is entirely on the looking at the patient. There is no investigation, no MR brain, nothing. As against that, this is a what is called as an essential tremor. This is not Parkinson. Why this is not Parkinson? Because it is coming while having an action, not while resting. So much so it is disturbing. He is not able to drink water. Now, patients of Parkinson, they'll be able to drink the water, but only when the hand is resting, they start having tremors. So many patients who come to the OPD saying, sir, I have got tremors, is it Parkinson? So I tell them that this is not Parkinson. They are so relieved because they are all worried. Parkinson means it is something like a sentence, life sentence. Okay, I think. Okay, so not slides, sorry. The videos are over. Okay, no, initially it was considered as a motor system disorder, inability to move fast. So now, as we keep understanding about Parkinson's disease, it is now considered as a systemic disorder. That means more than the motor condition, there are other features also. And those are not dependent on dopamine. The motor system is dependent on dopamine. So when you replace dopa, the motor component improves, but other things may not improve. What are all the non-motor symptoms that you will see? A lot more are there. Psychiatric features like hallucinations. Then there is a sexual dysfunction, siluria, urinary dysfunction, and sleep disorders, periodic limb movements, hyposmia. So I will come to this later. But fortunately, all these extra motor or non-motor manifestations occur quite later part in the disease and not necessarily in everybody. So that is one good part of the thing. We'll talk about the loss of sense of smell a little later. So that is how the recognition is entirely on the clinical basis. Decreased movement, resting tremor affecting one half of the body. Now, what are the measures to mitigate? How do we treat these patients? How do we lessen the burden on the patient? How do we lessen the symptoms and make the life of the person a little more meaningful? Now, if you look into the history of the management, after Parkinson described this in 1817, we started some drugs for only tremors, anticholinergic drugs, which are for tremors. And then once the dopa is discovered to be the chemical concerned with it, the oral levodopa started in 1969, which we are using it today. So before the levodopa came in, the surgery was one of the options. Look at the story. In 1953, Surgeon Cooper was doing a brain surgery unexpectedly. It's like a serendipity. Unexpectedly, he cut the artery which was supplying the basal ganglia. And to his surprise, he found that the patient who also had Parkinson, the tremors completely stopped. So it was a godsend opportunity to say, okay, this is the area. If I go and cut that area of the brain tissue, then the tremors can be completely stopped. So following that, electrocoagulation was started. But then once the Levodopa came into picture, where you can take oral tablets rather than go to a neurosurgeon and get a brain surgery done, so the brain surgery went into the oblivion, only to come back now. 1997 onwards, we have what is called as a deep brain stimulation. The earlier surgery was ablation or destroying the tissue. Now the surgery is to stimulate the area so that the dopamine can be more effective. So those are the, now that means we have a DOPA as the sheet anchor. Like insulin is for diabetes, DOPA is for Parkinson's disease. Now this is another clinical problem. The moment we make a diagnosis of Parkinson, it does not mean you have to start treatment. See, in patients with hypertension and diabetes, even though the patient says, "Doctor, I am fine. My sugar is only borderline. It will be 300." But he says, "That is because I ate gulab jamun on that day. Otherwise, I'm all right." But we insist that you must take treatment for BP and sugar because they're called as silent killers. They silently damage the kidney, the heart, the eyes, the brain. But in case of Parkinson never causes, it is not a life-threatening disease. It is more a disabling disease. It is not a life-threatening disease. And there is no medicine to prevent worsening of the disease. There is no medicine to cure the disease as of now. So what we are doing is what we call as a symptomatic management. That means if you have headache, you need not take crocin all the time. Say, chalega, it will go away. The other person says, no, I have got headache. I want crocin. So the treatment is only if the patient's requirement is there. If there is no functional impairment, then I don't give the L-Dopa preparation. But we give something like a dopaminergic drugs, which acts like Dopa, but it is really not Dopa. Then you may ask, sir, why you don't want to give Dopa when it is a specific drug? The problem is after several years, maybe about 10 years, lot of side effects of Dopa is there and lot of loss of effects are also there. Initially, the patient is well controlled with 2 tablets a day, maybe 3 tablets. As the disease progresses, he requires every second hour a tablet, every second hour. And with the result, the side effects of Dopa will come through, hallucinations, abnormal movements and all. Keeping that in mind, we should use these L-Dopa preparations at a time when the patient requires, not at a time when I made the diagnosis. Clinically, it is a little bit difficult in the sense that so when they come with a little tremor, I'll give you an example. A husband and wife will come into the OPD, then the husband, the patient. So I asked him, "Hey, what is your problem?" He said, "I have no problem." Then I said, "Why have you come to me?" Ask my wife. So when I asked the wife, "What is the problem?" "Sir, we go for walking every day. So as we are walking, he only moves the left hand. He does not move the right hand." So then I asked him, "Are you able to do all functions with the right hand? Brushing, mixing food, shaving?" "Yes, sir, I can do everything." So he is not functionally impaired. That means he can carry out all his functions. Patient is all right. So why should I treat him with L-Dopa? So wife said, "No, sir, it doesn't look nice when we go for a walk and all." I said, "Don't live for others, live for yourself. Why do you want to take tablets? Because that person may think what is." So it's important that diagnosis does not automatically mean the starting of the L-Dopa. They can start some other drugs like selegiline and all that. Now, even in the functional impairment, for tremors, we use a different drug. For bradykinesia and slow movement, we use the Levodopa. Then we have the patients in carefully selected cases. Many patients, they say, "Sir, 10 years, I am fed up of taking tablets. So I heard there is some surgery. I will undergo surgery." I said, everybody after 10 years of Parkinson is not eligible for surgery. We will have to select out the patients. So there, I refer the cases to our movement disorder specialist, Prashant, who is the chairman, who is in charge of selecting the patients for surgery, that is a deep brain stimulation. But important thing is surgery does not improve every symptom of Parkinson's disease. So selection has to be done properly. Now again, little bit of historical interest. Dr. Verma and Dr. Mani, the 2 pioneers. Dr. Mani was my professor when I was working in NIMHANS, and Dr. Verma was the contemporary neurosurgeon. These two pioneers were responsible for starting NIMHANS in the year 1973. Earlier to that, it was a mental hospital. Actually, when I joined here in 76, so I used to say, Elli kelsa marta idiri? I said, NIMHANS. NIMHANS? Elli? So I used to tell near Dairy Circle, oh, mental hospital doctor on you. So we were known as mental hospital doctors, even though we were a neurologist and neurosurgeon, because the mental hospital was upgraded into neurology, neurosurgery, and psychiatry, and a NIMHANS was formed. Now you know that NIMHANS is an institution of eminence in our country. So anyway, coming back to this, what Cooper did, that some serendipity, he cut some artery and everything became all right. So Dr. Verma was the person who invented this. He made a special needle where he used to put it through the foramen ovale here. The patient is on the X-ray table. There was no MR scan, CT scan, ordinary X-ray. On the X-ray table, because I have seen when he was doing that, because I was there. So patient is conscious, no anesthesia, nothing. Local anesthesia is given, and one needle goes through, straight away goes to the basal ganglia. And he knew with his hands that he is in the right place. So he used to inject a chemical, something like an ethanol and alcohol. And then immediately the patient who is on the table will be having like this, and then there's an injection given, and she said, God, patient comes out so happy, the tremors have completely disappeared. So that was the thing, but later on, it was not practiced elsewhere because they said it is not right. Now that we have got MR scan, CT scan, we require more permissions, more these things and all. But to tell you that how this gentleman, Dr. Verma, was such a skillful person that he could stop this, what people used to open the brain and do, he could do it as an outpatient in 10 minutes. What else is possible? We said medicines when required, then we said surgery in selected patients. Things are being worked out, gene therapy and stem cell therapy. You know that stem cell therapy, all degenerative conditions in neurology, any degenerative condition, Duchenne muscular dystrophy, spinal muscular atrophy, dementia, motor neuron, everything people are trying stem cell therapy. Stem cell therapy, stem cell therapy. None of them have been successful, scientifically speaking, but people keep on doing it for various other reasons. So here also the stem cell therapy is being tried. The stem cell which is transplanted is supposed to produce more dopamine. So that was the recognition is over, measures to mitigate the risk. What are the risks which can cause Parkinson's disease? Well, the one which has been corroborated, I would say association. It is not really that every Parkinson's disease is due to that. Association between pesticides and Parkinson's disease has been well documented. So those who are exposed to MPTP pesticide, especially the paraquat, on a long-term basis, some of them do develop Parkinson's syndrome. They don't have a degeneration as such. Then there are heavy metals also. Heavy metal exposure, especially magnesium, copper. There is a condition called as Wilson's disease where the copper is deposited in the basal ganglia, giving rise to a Parkinson's syndrome. So exposure to toxins, there are environmental risk factors. Repeated head injury, like in boxers or rugby, or there are some families where the moment you scold the person, they will go and hit against the wall again and again as a protest. So even that repeated head injury may result in Parkinson's disease over a period of time, but none of them have the original Parkinson's alpha-synuclein protein. Manganese mines and all that, where some of the people have developed the Parkinson's syndrome, but they don't have the resting tremor, and obviously they don't respond to L-DOPA preparation. So they are all actually Parkinson's syndrome rather than Parkinson's disease. Parkinson's disease still remains as a neurodegenerative disease. There are some genetic causes about, because normally the first question they will ask, sir, is this hereditary? Who is asking? The son. because the father has got Parkinson. The son is worried whether he is going to get Parkinson. So generally we say no, it is not a hereditary disease because it is not a monogenic one, there is a polygenic one. Having a gene in your body does not mean that disease has to be expressed. So one may have a gene in the body, risky gene, but one need not express the disease in that person. So generally, there are no methods to say whether the person has got a genetic cause for developing Parkinson's disease. Well, there are other risk factors on which we have no control. We can't stop aging because, as Dr. Parmesh said, that after the age of 80 years, 5% of us will develop Parkinson's disease. Maybe by then we have finished all our life's activity. If you are immobile, sitting in the chair, watching the TV, that's okay. There's no problem about it. So the risk factor is don't live beyond 80 years because you have only 5% chance of developing Parkinson. And then you can't select your sex. So if you are a man, more risk than the woman. So these are other risk factors. So overall, the conclusion is that a combination of genetic factors and the environmental factors can give rise to this. Now, another 3-4 slides. Is it okay? Yeah. So statistics, you know what statistics are. It is said that statistics is the second biggest lie. So they collected statistical data and then they are giving it to us that if you want to protect yourself from Parkinson's disease, that is original one, drink a lot of coffee, smoke to the glory, whatever you want. And so, but as Hermesh said that none of us are telling you to drink more coffee and start smoking, because probably if you start smoking, you may die earlier with cancer lung, so you may not get Parkinson's disease. What do you say? That may be one way of saying that smoke and you will not get Parkinson. Now, can we prevent or at least modify the disease? Now, this is for the Indian Institute of Science people. We know that multiple sclerosis, we have disease modifying therapy in multiple sclerosis. We modify the progress of the disease. So, is it possible to prevent or at least can we modify? Why? Remember, 60 to 70% of loss of dopamine, then only it produces a clinical disease. Can we catch when they are 10%, 20%, 30% and prevent them to have 70% loss? So that is the question. That is called a pre-symptomatic stage before the symptoms of Parkinson's occur. Now, interestingly, this Bragg hypothesis. Now, let me go back. Alpha-synuclein protein. Now, he has discovered that protein not just in the brain, but in the olfactory nerve, the nerve for the smell, and even in the gastrointestinal tract autonomic nervous system. So he says that the Parkinson's disease actually starts in the gut and also in the olfactory nerve, and together there are two entries from the gut and from the nose, and then they enter the brain and then they cause the Parkinson's disease. So can we catch before they enter the brain? So how do we do that? So early recognition before the 60 to 70% occur. Now, how do we recognize? There are 3 parameters. You can recognize clinically before the disease starts. You can recognize by investigation, imaging, and some fluid and tissue biomarkers. How do you recognize clinically? There are a good number of points have been described, but to me, most of them are age-related. I mean, constipation, depression, anxiety, erectile dysfunction, urinary dysfunction. Most of us have in the senior citizen. So it doesn't mean that they are going to develop Parkinson's disease. But one thing they have correlated is the loss of smell. Loss of smell as a precursor for Parkinson's disease. Now, how important is loss of smell? 50 to 90% of patients with idiopathic Parkinson's disease have loss of smell. Normal population above 50 years have got 25% loss of smell. Idiopathic olfactory loss, somebody who has gone to ENT and says, I'm not able to smell at all. When you follow them up over a period of 4 years, 13% of them have developed Parkinson's disease. and very important for us clinically to differentiate idiopathic Parkinson from Parkinson plus. Loss of smell is a pointer for idiopathic Parkinson. But don't go back home and start smelling agarbatti, smell, scent, and then what your wife has prepared some food, and they say, oh God, I don't have smell. Doctor said I am going to develop Parkinson's disease. The commonest cause of loss of smell, as you know, is cold and cough with the coronavirus running around. So that is also one other thing. But all those things excluded, if somebody has olfactory loss, maybe it is a clinical marker, maybe. Then what are the imaging markers? So we have imaging markers, SPECT and PET, and also transcranial sonography, which demonstrates hyperechogenicity in the substantia nigra. But more often what we use is a PET scan and SPECT scan. So this PET scan shows the metabolism of any part in the body. It shows that the patient has got a, on your left side control, you see those are the basal ganglia with normal metabolism. On the other side is the Parkinson patient, which is faint. That means the metabolism there is very much less. That means the production of dopamine is very much less. The other imaging is called as a DAT scan. Now here it shows us the dopamine availability. The previous one shows the dopamine generation, and the second one shows the dopamine availability. Again, you can see that the patient has got dopamine availability is less. Occasionally, people have used SPECT scan to differentiate a tremor which is due to Parkinson or is it due to a essential tremor. Sometimes it is clinically confusing, but we don't use it in our day-to-day clinical practice. Lastly, the biomarkers to find out where is the alpha-synuclein protein. So that is a tissue biomarker or a fluid biomarker. So if you are able to find out alpha-synuclein protein in the fluid like CSF or saliva, or in the biopsy tissue, even in the gut, it may be a precursor to say that the patient may develop Parkinson's disease, but these are all still in the laboratory. We have not yet started applying clinically. So if and when, why do you want to diagnose just before the Parkinson's disease occurs? So that you can prevent the progress. But until we have something to prevent the progress, there's no point in saying, hey, come here, I'll do FDG PET, I will do SPECT, and then say, you are going to develop Parkinson in the next 10 years. That fellow is enjoying the life. Now you go and tell him that you are going to develop Parkinson after 10 years. So he'll be depressed completely. If there is a medicine to prevent the progress, then it will be clinically applicable to screen the patients. Until then, it is more a research area. So once the neuroprotective therapy has been developed, then we can do a systematic screening for prodromal Parkinson, like clinical imaging or tissue biomarker. So until then, it is purely in the realm of research. Let us hope one day we'll conquer this neurodegenerative disease. At one time, we thought Duchenne muscular dystrophy, there's no treatment. Spinal muscular atrophy, there's no treatment. But today we are having treatment. So maybe a few decades later or a decade later, we'll be able to have this. So I look forward to this prestigious institution, Indian Institute of Science, which, as all you know, that they are going to start a postgraduate medical institution, not for giving a MD, DM and all, but to encourage them to do the research laboratory. So I hope that Indian Institute of Science will come out with a disease-modifying therapy for Parkinson and put our country in the map of the world. Thank you.
Thank you. Thanks, Professor Srinivas. I think it was quite a lucid talk on Parkinson's disease. Most of us, even I was sitting and listening, it was like teaching for LKG student, go through everything, understand from beginning to end what are the symptoms of Parkinson's disease, why it occurs, and how do we treat it, what are the risk factors. Quite well covered. That's what I can tell you, everything when you look into it. I know that most of you are looking into from a basic sense perspective what is going on in Parkinson's disease and what we are looking for. As put forward, Parkinson's disease is a big probably a disease per se is a misnomer. What has of late has been discussed is it's not a disease, it's basically a syndrome, it's a set of symptoms. All of us with aging have to become slow, and these are the changes which all of us go through. One of the slides where it was told as 5%, I slightly disagree, it is 50% what we are looking for. One of the studies tells that at around 85 years of age, by 85 you are still alive, you are in 1 in 2%, either you have dementia. If you don't have dementia, then you have Parkinsonism. So either you are in this basket or in that basket. So everyone has to develop slowness. Everyone has to develop cognitive decline with time. There are various pathological changes, pathogenetic changes are happening. And now, in Indian perspective, also a lot of research is going on. Currently, whatever we knew was basically from the Western understanding what we had, and especially when it came to genetic aspects. What Professor Srinivas was telling about 5 to 10% have genetic risk factors. Till 1990s, we never knew why Parkinson's disease was happening. We just knew something was happening in the brain, and a lot of research was associated with the environmental risk factors, various other factors which could be confounding for occurrence of Parkinson's disease. The first diagnostic criteria which was defined for diagnosis of Parkinson's disease, it was told that patients should not have any family history of Parkinson's disease to diagnose Parkinson's disease. However, as soon that publication came out or that criteria came out, within 2 years, the genetic forms of Parkinson's disease was recognized, and after that, what we tell that everything is still. Lot of genetic forms have been noticed. The initial few years, let us say from 2000 to 2010, lot of public Indian replications of genetics of Western studies, whatever we have seen, most of these were negative studies, what we noticed. It already meant that we have Parkinson's disease, but we don't have the same genes what we are having there in the Western countries. So now, currently, a lot of studies are happening, especially on genetics of any onset Parkinson's disease. Genetic genome association studies are happening, where Michael J. Fox Foundation is also funding various. There's a consortium which is working in India called as Parkinson's Research Alliance of India, where we are able to see quite a bit interesting findings are there, and especially there is difference between North India, East India, South India, and the problem what we are saying is South India has much more consanguinity down there. The South Indian consanguinity rate is very high, and the genes what we are finding the South Indian populations are quite different from the North Indian or the East Indian, and quite a bit of lot of new mutations are also being picked up down here. So probably with this, I will give a concluding remark here. Any questions, please do ask for Professor Srinivas. If nothing else is that I may be forced asking questions which I don't want to do it. As the chairman, I have obligations to ask. Thank you. Please introduce yourself and you can ask the question.
I'm Samitri Ranganathan from the Degenerative Center. So you mentioned that the male gender is more prone to this. Is there any biomarker which has proven this, or is the cause?
There is only statistical data where you find there are more male members or male sections who have this. I don't think there is any biomarker.
I think currently a lot of things are going on to understand, especially when it comes to estrogens related changes, what is happening in the genetic aspects. There may be some protective effects why males are slightly more affected as against females. But what we should remember, most of the early publications were in relation to the limited answers what we get. But once you see that, once you cross 45-50, that estrogen related protective factor goes away also. Probably in the general day-to-day practice, the way I see or the way Dr. Srinivas sees, we don't see that much of disparity. It is just a number, or it may be other way around to tell that men come or men are brought to consultations more. It's a memory of socioeconomic or various other ways to tell the same aspect why that might be happening. But we don't have a clear-cut answer. It is one of the points which is picked up, but not very standing or glaring out.
Generally, if you see in the hospital, men patients are much more than the women, because women are not brought to the hospital first because the preference is given to the earning member. I am talking about men who are the sole earning member. I am not talking about present generation where everybody is earning member, everybody is self-dependent. So that is the reason if they have a little bit of money, they want the earning member to be first addressed. The family, the wife will say, first you go and get your electric, it doesn't matter, I will somehow manage. So that bias is also there in many of these statistical data, where we say that men are more like that.
I also observe, this is working, this one. I also observe one more thing, why you call it as men versus women, because these are all postulations when you go into it. Women are much more active. They may be doing dual work. They may be working at offices. They may be working at home. They keep their lifestyle very active as against men. Most of the men, once they reach 57, 58, 59, once the retirement comes, if they are working people, once they retire, they take completely a sedentary lifestyle. And that is when most of the time they tell that Parkinsonism symptoms were noticed just when they retire. The lifestyle dramatically changes for men. Women continue to have a very active lifestyle even in their home also. And having a good active physical lifestyle, personal lifestyle does slow down Parkinsonism. Because that is what we tell for every patient with Parkinsonism. So it's only a question of how you want to see it. Probably not much in detail has been given because the disparity is not very big. It's a small, like I said, I think 1.3 to 1 or something like that, or 1.2 to 1 it is. So it's not a very big number, and there are various ways to describe it.
Do we have a DBS center in?
This has been observed across the globe.
Everywhere, I'm not talking about India. The same holds good for Western countries also.
But as we understand, the Western countries, irrespective of their age, keep themselves physically fit and active.
I don't think so. I don't think so. Men are men everywhere. Okay, that's what you should remember. I think grass is greener on other side. That's how it is. I know my friends, my colleagues, everyone. Men are men everywhere. That's what I tell you.
Do we have a DBS center in Karnataka?
Oh yes, DBS, quite a few places in Karnataka they do it. In India, a lot of centers do it. So no question about it.
Bangalore?
Bangalore, yes, all the hospitals do.
Because many people say the DBS is a better treatment than the drugs because drugs have got their own side effects.
I don't agree with that. The point is each therapy has their own roles and they have their own specific window period when it works out. If there was a curative therapy, then whatever is curative, we can agree with that. Whatever we are doing at this point of time is symptomatic therapies. Symptomatic therapy means how you are to make it better quality of life. And always, whenever you do any therapies, the risks should be less than the benefits. Benefits should outweigh the risks. That's what we tell you. So that is the reason even though surgical therapists, what Sir was telling you, that started in 1950s and 1960s, they went to backbench because medical line of management could overtake it. The risks associated with surgeries are also there. That came back. So DBS has come only to those patients where medications are working, but they have started to get limitations of medication in those subset of patients. We suggest that DBS will help you to have a better quality of life for a better few years. So we call it a, what we are doing with medications is a pulsatile therapy. You take medication, effect comes, goes, effect comes and goes. We move on from there to continuous dopamine stimulation. Like insulin, people take with pens, and at some time they will go with insulin pumps, right? Something which can give a similar type of response how the body's basal rate of insulin release is there. Similarly, we do DBS or other type of tests. We have patch therapies, we have apomorphine pump therapies, or Levodopa, carbidopa, intestinal gel therapies. All these things to give a steady release of dopamine. Recently, I was reading one article. New probiotic drugs capsules have come up. They are studying it, which is going to be published at AAS. They are trying to see how those probiotics can be used to release dopamine on a constant basis as per the body requirement. So that is what is required to meet on us. We are trying to give whatever is the deficiency here.
It's almost like a cardiac.
It's a pacemaker, basically.
See, as I mentioned that in selected cases, DBS is effective. Now, what is selected cases? The doctor who is doing he is involved in the DBS now. So we will look into all the aspects. It is not that I'm fed up of taking tablets. Give me a DBS. I heard that it is very good. I mean, that That is how the patients come. It is not that everybody is eligible for DBS.
And also people think that if they are going for a costly treatment, which is better treatment. That's not the
What is the cost involved here? Cost of the therapy.
cost. It varies from 10 lakhs to 20 lakhs based upon what. And there are various things which are involved down there. Okay.
But it is not the fees of
not equivalent to the cure.
it is not the fees of the surgeon or hospital. It's very important.
Yeah.
It is the equipment.
You are completely after paying 10 lakhs.
That's the question. That's what I said. People think that money is equivalent to the cure. It's not like that.
I wish money can buy the health, in which case no rich person should die. Isn't it?
Yeah. Anything else? Anyone? Yes.
I'm Balaji from Data Center. So see, this Buddhist monks live for a long time. And there are any studies where they do a lot of meditation. So cognitive dissonance, cognitive disorder. So are those people getting? Is the fraction of Buddhist monks getting Parkinson less? Or are there been studies elsewhere in the world?
You mean to say sleep studies are done on meditation, which can reduce the.
I don't know whether any correlation.
See, meditation or yogasana in that last yoga nidra and all, they do reduce the amount of stress a person experiences. So anything the stress is contributing to the disease. Now, for example, the tremors, the moment they see a new person, his tremors become more. So no amount of drugs is going to stop the tremor because they become anxious. The fellow will see that I have got a disease. Now, if the meditation can reduce that sort of a tremor, then it may help. But I mean, the whole outlook will change in meditation. It is good for everybody, and it is good for every type of disease. But it is not a direct effect on the Parkinson's disease.
I think so. Answer the same thing would be Buddhist because there is no specific study which is available, but at least we know that the Buddhists who are having Parkinson's disease also other way around to tell. So it's not as simple as that. But what Sir was telling is very much right. The stress, quality of life does play a lot of role. Previously, we used to consider Parkinson's disease as pure aging-related disorder, and people should develop symptoms only after late 50s or 60s, something like that. However, of late, I don't know whether because in Bangalore or whatever, we are seeing quite a few young onset Parkinson's, means those who develop symptoms before the age of 40 years. We, across India, we started to work on a project called GOPI-YOPD, that is genetics of Parkinson's disease or young onset Parkinson's disease. Within 2 years, we collected one of the biggest series globally published, which was clinical data was published down there. One of the reasons, probably in Bangalore, I can tell that a lot of people are working 12-hour shifts, night shifts, day shifts, going in the round. So stress could be playing a lot of role. Plus, recently with the COVID infections, also a lot of concepts are coming about how these long-term stressors can have effect, because possibility of postulation is also being put forward that whether people who had COVID have a more predisposition to develop early Parkinsonism symptoms because how the body chemical reactions occur or the stress reaction, because it's basically a stress and oxidation related changes what happens in a lot of chemicals which in the brain and so on.
Just scientific curiosity. Is it DBS, you open the skull or you access it CT guided needle?
We put a 25 paisa size type of a 2 holes, burr holes, what we call it as. About it will be around 9 cent, I think about 1.5 inch in length, in width. That's what it is. About 25 paisa size. That's the best part I can tell you. 2 holes what we put here for each side of the brain. If you are putting only one side, 1 hole is good enough. And from there we put the electrode, whichever part of the brain you want. Because DBS, once again, as we saw once again serendipity only the weight is going on. So we give currents of different, it's a high frequency what we use down there. But what we have noticed is lower frequencies help for different set of symptoms also. So high frequencies will help for our bradykinesia, tremors, slowness and tremors or stiffness and tremors. Lower frequency help for axial symptoms such as speech and balance. However, for the same perspective, we have been trying DBS for various, because once we don't know it is working for one part of the brain, we should work for any other degenerative changes. Similarly, research is going for dementias and other aging-related disorders, but probably that eureka moment, we are not able to get that, hit that one, I think one more term of serendipity is required to get those answers. So we don't know a lot of questions, remains unanswered. First half is under local anesthesia, then second half is under general anesthesia because we need to assess where the electrode is sitting. We assess on the bed whether the person is having clinical benefit or not. Then, because it's a very small nucleus where we are targeting, and we need to make sure that, doubly sure that where it is sitting, whether there are certain thresholds to take that much of current or not. That's what we look into it.
Whether
I
it
think
was
people will work, a lot of people will be working, so it will definitely advance. Like cardiology, I think the surgeries have come from interventions.
Yes, most of the things currently is non-interventional. People want without doing it. That's why nanotechnology, everything is coming, right? Our laparoscopic surgeries where least of the incision into the body and unseen incisions to get the best of the clinical benefits.
It's like a tender coconut. Put a small hole, you stick it. So that hole will.
Where are we going to fix that electrodes?
In the brain. No, in the once the electrode comes, we put a battery below here, the clavicle bone here. And this from the battery sits on the chest. From there, the wires go below beneath the skin, and from there it is connected down into the brain. That's all.
Prashant, does this for that frequency of current which you give, it is focused on that particular area, but does the surrounding area also gets to some extent affected with that?
Yes, because it depends upon the current amplitude, pulse width, and the frequencies. How much is the tissue is getting, what you call it as activated. That's the easiest way for me to tell. It not only depends upon that based upon pulse width, whether the thinly myelinated fibers, unmyelinated fibers, or thickly myelinated fibers. So those type of neurons are also we are looking forward for because we use different pulse widths. When we use different pulse widths, different type of benefits we get it. So it does change based upon the current and voltages. What is the tissue being affected? So if it is not sitting in the right position or it is sitting at the edge of the position wherever we want it, then it may stimulate other surrounding tissues, which causes technically side effect. Because the patient gets an unwanted effect which he shouldn't get it. It's medical, we call it as an adverse effect. So in those set of patients, we need to adjust the currents, voltages. We go from monopolar settings to bipolar settings, or we use this and amplitudes. That's how it goes on.
How do you identify the particular issue which you have to have the under the imaging techniques?
Correct. I think what Sir was doing initially was the X-ray based approach because that is a highly skilled surgeon who knows where we are going and where we are putting. That's very simple about that. But currently what we do, we use different methods to make sure that we are in the right place. First, we definitely do all the patients have to go on MRI, and based upon MRI, we know that where that structure is located. Once that we know where that structure is located, we use, because for DBS is a functional surgery, we use a frame. Frame is like a XYZ coordinates, right? Like for physics, we have this all that Scattergood's atlas is there, where they have already put if you go X depth, Y depth, this is what comes down. So now those are softwares are there. Based upon that, we mark it from this contact point. If you go down, where we are sitting down, and once we look into it, then we put electrodes to understand whether we are the same amount of same tissue is getting stimulated or not. So each tissue has different firing patterns. So that's what we look into it. Then we go for a clinical stimulation to see whether patients are benefit or not. So different ways of doing it. I think that's good. I think we'll finish with that. We have taken long overdue time on it. Thank you.
Can I ask one question?
Yes, madam, please go ahead.
He was telling copper, iron, excess and all. What is excess, what is normal, and our ancestors were telling us to take this one, any roti, you should do it only in the iron tawa. And then copper, the bath also to be taken in the copper vessel. Drinking water also should be copper vessel, so that iron and hemoglobin also will be increased. So that's what I want to know.
Ask the expert.
Well,
This is wrong. I think madam is unnecessarily delayed.
But my answer.
I think the point has been that there have been a lot of copper-related disorders were there, and especially giving an example, like Indian childhood cirrhosis, which was down there, where people told that these subset of patients had a lot of copper deposits in the liver, and one of the theories was that people were using the vessels which may not be the truth also, right? So that is the point. These are assumptions, means you see what is their causal associations are there. And nowadays we don't see those type of disorders happening down there. Either we have know what is happening down, or we have changed some of our lifestyle, because socio-economic lifestyles have changed so much. We don't know whether it was related to copper related changes or iron related changes or the vessels what. Because absorption in the body is also dependent upon so many other factors. It's not as simple as that you take something which is done on a copper vessels, it directly has an effect. But I don't know in depth whether it actually makes a difference. But currently, I don't think we don't ask those type of questions. Neither we see detail for those type of issues happening in clinically based as such.
Thank you.
Students in the faculty are not in Parkinson's.
No more questions, please.
I think I forgot to recognize.
You can ask me in the house. She's my wife.
I was just going to. I forgot to recognize the presence of Mrs. Srinivas. She is also very well known of the gynecologist and NIAS member also. She is also interested in environment related issues. I think I do recognize the presence, but I'm sorry I didn't mention earlier. And before we give vote of thanks, I request to give our mementos. I call our mathematical genius of our institute, Professor Balaji. A small token of appreciation from our institute. And also for the chairman. Sir, you stay here. We're going to have a picture. And now I request Dr. Jayaj Rao, who is the past president of the ComHAD India chapter, to give vote of thanks. Dr. Jayaj Rao. He is a pediatrician also.
Good evening. I feel extremely happy in many ways to have Dr. H.V. Srinivas and Prashant here. Particularly, Dr. Srinivas is a well-known neurologist in this part of the country. I heard when I came to Bangalore during 1975, he was a top-class pediatrician. I'm a neurologist, most sought after. And he covered etiology, diagnosis, clinical features, and lastly, treatment. And now the youngsters should feel or should get some kind of courage from his talk. At this age, he has so much of interest in this neurology, and he came here all the way from Jayanagar probably, if I'm correct. JP Nagar. Nearly about 20 kilometers. Look at his interest in academic activities. Sir, we thank you on behalf of the Commonwealth Association for Health and Disabilities India chapter and Devacha Center, Indian Institute of Science, Lakeside Medical Education Trust, profusely. Both of you, you have spared your valuable time here. We have spent a nice time. We learned a lot from you. I once again thank you profusely on behalf of this association. Thank you very much.
We have a picture, sir, with a bulletin board.
No, I have forgotten. Audience, you people are more important, and you have spared your valuable time to attend this talk. Thank you all. Thank you very much.
We can all have a picture.
Yes,
No, sir, it's okay, please.
Questions create a lot of interest.